Hi, good evening, friends. Welcome back to Boss Lady Live. I know we have been on a break for a while, and many of my viewers have been complaining and asking me when I'm coming back, when I'm coming back. So we are back. We are back with season 2 of Boss Lady Live. Our last uh, 14 episodes were so informative and welcomed by our guests. I mean, season 2, people have been waiting with bated breath. And who better to kick it off with but Dr. Astrid Batchelor? And we're going to be speaking on penis. Well, we spoke on penis health, so now we're going to be speaking on vaginal health. I promised you, right? So we're going to be speaking on vaginal health. Let me just introduce my guest. Remember, share with your friends because you don't want them to miss this information. Like and share and subscribe to our Totally Male Spa YouTube page. And if you look on our Instagram page and our Facebook page, you'll also see the social media contacts for Dr. Astrid Batchelor. Okay, so Dr. Astrid Batchelor is an obstetrician and gynecologist trained at the University of the West Indies. She is a fellow of the American College of Obstetricians and Gynecologists and an associate member of the Royal College. She's an expert in women's reproductive health and wellness and is passionate about health, education, promotion, and advocacy. Dr. Batchelor has a special interest in infertility management and offers quality antenatal and gynecologic care to the Jamaican population. In her free time, she still finds time to cook and travel. Welcome, Dr. Batchelor.
Thank you. Thank you so much, Sandra. Thank you for having me, and thank you for having this platform to inform
Yeah.
your viewers of all the issues, penile health, vaginal health, and all the other great and
And
interesting
all the other
segments.
kinds of, yes, because we need a forum where we can have these discussions
Yes,
because,
of course.
out there, well, especially, I thought of this platform, especially for the men, because, our men, they don't like to seek the knowledge. So we have to bring the
Yes,
knowledge to them. And they have been participating and they have been enjoying and they have been giving me feedback. So it is wonderful that
yes,
you're here this evening because vaginal health is not only about the woman, it's
no,
about
it's
the
not
man as well, right?
right.
Because we all participate in vaginal health, right? It's a responsibility of not only the female, but the male as well.
Yes,
Everything,
yes,
joint care. It's about caring for each other. If you are in a relationship, the responsibility is just as well as mine as it is yours. So I want
yes,
to
it is.
first of all, my friends. Oh, hi, Mr. Henry. Hi, Patricia. Hi, Anika. Welcome. Thank you for tuning in. We're back. I know Mr. Henry has been very lonely for the last few weeks. He has been thirsty for us to come back. So we are back, and he's very excited about the topic because we have Mr. Henry. He's in education, and he's one
Okay.
of my very faithful clients. And so
Well, hello,
we
Mr.
always
Henry.
have our we always have that conversation on a Saturday about our power about our online meetings.
Yes.
So we want to kick off by just speaking. Well, first of all, just tell us a little bit about yourself. How long you've been doing this, why you even chose obstetrics. Well, you gave us a little overview, but just
Mhm.
tell us a little bit about yourself because we like to know who we are speaking to
Of
because we are
course.
now a community, we are now family. So can you just give us a little overview? Because I've never
Sure.
heard of you before, and let me tell you, people, let me tell you how I met Dr. Batchelor by total, I would call it divine intervention. I was calling another number, and somehow the number I called, she answered, and I told her my plight. that I needed, as I was sent to her clearly, right? I needed a gynecologist to come and speak on vaginal health. And she immediately said yes. So, we have the right person with us. It
Yes,
is
it was
divine
definitely
intervention. Uncanny.
because that's actually, vaginal health is actually one of the most common issues that I see in my office, as well as the questions that I get from patients online and on the phone. It's always usually about something related to vaginal health. So when you called me, it was really, really divine intervention that this happened, that I would be able to get this platform to come and speak about it. So
I always had a direct line to God, so I'm now proving it.
Yeah, so
Yes.
I'm Dr. Astrid Batchelor. As you mentioned, I'm a graduate from the University of the West Indies training program for obstetrics and gynecology. I've been in this field now for 5 years. I am just passionate about anything having to do with health education and health promotion. That's one of my favorite things to do, to counsel patients and to educate them as well about their reproductive system.
Right.
I am currently practicing at 2 locations. I practice at Gynae Associates in Kingston, as well as FemCare Gynecology and Pregnancy Center in Kingston.
Yes.
And I also do 1 day a week in Portmore to serve that population as well.
Right. And so, okay, so let me. Usually our guests, they normally feed us questions, but let me kick off by asking, in your practice, would you say we as a nation are on top of things in terms of our feminine wellness, for want of a better word? Are we taking care of ourselves based on what you have seen? Are we knowledgeable? Do we need to expose ourselves more to what is out there? In terms of infertility, we'll get to that soon.
Sure.
But in terms of, are we knowledgeable about taking care of our bodies? Because I don't know of any. In growing up, I don't know about now. In growing up, the information was very limited. So I know everybody has access. Well, not everybody, but most persons now have access to online and internet and all of these things. But in your day-to-day activities, and I don't know who your clientele is, but what would you say we are on top of things, or we really need to
Well,
get
what I would
more
say is that we
information?
have become a lot better, Sandra, over the years in our health-seeking behaviors. So the majority of my patients, 95% of my patients, are women, because I do gynecology and obstetrics. And of the 2 sexes, women tend to have better health-seeking behavior
Right.
between men and women. So what I would say is, there was a time when persons would have issues and they wouldn't seek help. They wouldn't go to a doctor. They might know something is wrong, but they might not have health-seeking behavior. So that has definitely improved over the years. More women now are interested to see their doctors, to actually speak about problems that they are having. Now, you ask a different question in knowledge. So
Right.
knowledge is what we need to work on now. So we have the health-seeking behaviors, but now
Right.
we need to work on the knowledge. And so that's where the education comes about. I'm actually so glad that in the last few years, more gynecologists have taken to the medium of social media
Right.
to basically educate persons, not only advertise services, but to educate the public about when it is that you probably need to seek a physician's help or to seek a
Right.
gynecologist's help. So I would say definitely, as a population, we're becoming much better, much better with seeking help, especially about our bodies and about reproduction. And as you said, we'll get into infertility later. I'm sure
Right.
that's a hot question.
Very, very hot button. Yes. So okay. So in general, okay. So at what age would you say a young lady? We know about puberty and all the things that come along with puberty. But the frequency, in terms of frequency, in terms of checking the gynecologist, and what are some of the things that we need to look out for? We need to investigate. What kind of tests we need to be doing? That kind of thing.
So I'm so glad you asked that question, because a lot of people think that gynecologists are just for adult women, or for pregnant women. I have persons in my office who tell me they didn't
Because
know
that's normally when we
people
start
saw
going.
Right. Why would I go to a
Mhm.
gynecologist if I'm not pregnant? So
Right.
I would actually say that your relationship with your gynecologist should be initiated as early as the first period. So that's really going out to the parents now. So
Right.
as the young female has her first period, that is a good time to initiate a conversation with the gynecologist. And if the period hasn't started by age 14 in girls, then you should actually start taking your daughters to the gynecologist to find out if something could potentially be wrong, especially
When
if you.
when is a young lady supposed to see her period?
So
Is
on
it the
average,
average age?
yes. So on average, the range would be between age 9 and 14.
9 to
So
14.
anybody who starts earlier, if you have an 8-year-old who is menstruating, you should take her to see the doctor because she may
Right.
have what we call premature puberty, right? So we need to get her hormones checked. And if you have a teenager at home who is older than the age of 14 and has not started seeing her periods and does not have what we call secondary sexual characteristics, just meaning that you don't see any signs of breast development,
Mhm.
she hasn't started growing hair to the pubic area, then you should also take your daughter to the gynecologist to be evaluated. So a lot of times these first visits, so your daughter has started menstruating, she's gotten her period, right? It's a
Right.
big event in a girl's life. It is, it's huge, you know, and
Right.
sometimes they're not even sure of what the symbolicness of it is, right? And so you have a lot of these girls, they're going to school, their friends will teach them these things if you don't. And we don't know the information that they're getting, if it's correct information. So it's a good time to initiate this conversation with the doctor. Sometimes these visits are really just friendly visits so that they don't have a
Right.
fear of going to the doctor, a fear of talking
It
about
would be good if my mother had taken me because my mother only told me when I saw my period, if boy touch you, you get pregnant. That was the
right.
extent of our conversation. I
So
know it's
that is
different now because everything is in the palm on the phone, so you don't even have
right.
to ask your mother. But I
Hmm.
mean, many of us back in the day, that's the conversation. Don't make
Yes,
boy touch you
that is it
because
because
you're
you'll get.
now able to get pregnant, kind of thing.
So, and they
Yes,
don't even understand sometimes what touch means at this age,
right,
especially when you tell them.
absolutely,
So it's a good time to start. The doctors can educate them about their menstrual cycles, educate them about some of the things that might be considered normal or abnormal, because sometimes, your parents don't know these things. Everybody has a different experience. The child got her period and she hasn't gotten it again for months, and everybody
right,
is, they're not sure really what is going on. So it's a
mhm,
good time to speak to a healthcare professional about what is considered normal at this stage.
right,
um, find out about what's going on at school, because there are some things that your teenagers, your tweens and teens don't even tell their parents, right? But they will tell their physician once they've established a good relationship with the physician. It's a good time
mhm,
for us as well to screen for certain things. In any pubescent child, there is all right now, we have issues with bullying at school, depression,
mhm,
early initiation to sexual activities. So it's a good time as well for us to start speaking to this young teenage girl about what's going on in her life as well, and some behaviors that we can start to modify, or any issues that we may catch at this stage in life.
right. I
Mhm.
can recall I had one or two friends that you knew when they had their period because they were absent from school. Because they
Right.
had like heavy bleeding, very bad pains. And we never heard things about endometriosis, and nobody had those kinds of discussions with us.
Right.
I mean, and so, I mean, I had a young a friend that, I mean, from I know her, she has always had period issues, and eventually she had to do a hysterectomy and all of that. But it started from early. And so what it means to me is that no attention was paid to it. You just know that she have bad periods.
Right. And
That
so,
kind of thing.
right.
It just gets a label and it
Mhm.
stops there because 16-year-old and
Doesn't
18-year-old have no business going to the gynecologist. That's the thinking.
right. So they're at home with their hot water bottle.
Absolutely.
Right. Yeah. So a lot of these things are treatable. I mean, in this day and age, no child should be staying home from school because of periods. There are things that we can do, there are treatments that we can give, because at this stage, a child needs to be functional, both socially and academically. So we need to, if it is that we need to intervene at this point in time to help her manage her periods better, there's
Right.
medication treatments that we can administer. So
Right.
it definitely starts from the teenage child that they should be seeing their gynecologist. They should start off with their regular checkups as well. They don't necessarily have to see the gynecologist every year,
Right.
um, as older women should, but they should have a healthy understanding of this relationship with a gynecologist and also about their own reproductive health.
Okay. All right. So we have, okay, so Dr. Aiken is telling you good night.
Oh, hi.
And Dr. Henry says, are you an immaculate girl?
I am. I'm an
Yes, so he
immaculate girl.
says he knows you. That's Mr.
Okay.
Henry. Yes. So Mr. Henry says, can we determine vaginal health by just looking?
Okay. So definitely not.
Okay.
There are lots of
So
things we can't.
give us a
So
little
one,
breakdown on that.
right. So vaginal health has to do with more than what meets the eye, right? So the vagina, as you know, is an organ that is on the inside of the body,
Right.
right? So a person might come with symptoms, and when you have a look, everything looks normal on the outside. And as gynecologists, we have instruments that we can have a look on the inside of the vagina too.
Mhm.
And sometimes you examine the vagina and things inside also look normal, right? So sometimes we have to do further testing. We have to do sometimes we have to test persons for STDs, for pap smears, where we actually look on things on a cellular level.
And not all STDs show on the outside or
Right.
any of
Not
them.
all
Right.
STDs even have symptoms, right? Not all
Right.
STDs have symptoms. Sometimes I have young girls who come in just for their regular pap smears, and we screen them for STDs, and you find that they have an STD. They didn't even know, they don't know where they would have picked it. They're not sure which partner they may have gotten it from. So
Wow.
it's not something that we can't always just look at the vagina and say everything is normal, everything is
Right.
healthy. This is why we do screening tests as well.
Wow. Okay. I think you were saying something else when I interrupted you. You were going in to say, anyway, we'll pick up back. All right.
Oh, what I
So
wanted as
yes.
well was you were talking about when should somebody, the relationship with the gynecologist. I had
Right.
started off with adolescents, and your relationship with your gynecologist is going to change as you get older. So you
Right.
move from, starting periods, that's usually the adolescent female, then you're going to move into your sexual debut, your first sexual experience, moving into now your sexual relationship and journey that you're having, in which now
Right.
your relationship with gynecologist might change now to need for contraception.
Right.
Right? So, screening for STDs, need for contraception, pap smears. Then, as you enter into your reproductive life now, when you decide you want to have children, then now your gynecologist will also take you through that journey as your obstetrician. And then you have the years after that, after having children, where it's now time, you're in your 40s, it's now time for your mammograms and continued screening. Then you go into the other phase of your life, which is now into your menopause. You start having menopausal symptoms, and
Mhm.
then we are right there with you too at that point in your life, helping to guide you and help you through your menopausal transition, as we call it. And then you
Mhm.
have what we call the geriatric phase of life, when you're going into your 60s and 70s, which also comes with its issues as well. Women may start having problems with prolapse, where they have issues where they have issues with their vaginal supports or their pelvic supports as well, and they may need correction of this issue with prolapse, what Jamaicans like to call body come down.
Ah, yes. Yes.
That's
Yes.
pelvic organ prolapse, right? So, as it's a beautiful job. You had asked me why I liked it, and it's a
Yes.
job where I can actually grow with my patients and
Right.
aid.
Absolutely. Now
Right,
that you say, I never really looked at a gynecologist like that. I mean, I started going to the gynecologist in my adult year when I was able to pay the bill. So I
right,
never went. I can safely say my mother never took me to the gynecologist for whatever reason. Well, the truth is, I never really had heavy periods or anything like that. So I suppose in her mind, there was no real reason to take me. So, you know what I wanted to ask you, Doc? Things like, all right, so men go to the doctor for penile dysfunction and to things like that. When it comes to women, do we have any of those sort of issues? Or, well, I mean, some people, they don't have, what you said, they don't get turned on very easily, or some people can only have an orgasm with clitoral stimulation. Is that something that the gynecologist also gets involved with?
Yes, definitely. So,
And you only come to the gyno when you have when you think you have a serious issue, or is it something that you say, I can come to the gyno and say, okay, I can ask you certain questions with regards to, because many of us, apart from reading,
mm-hmm,
the sexual, because I would say up to about the age of 30, I
mm-hmm,
thought is the man alone was supposed, no, let me say about 28. I thought it was a man alone I was supposed to be having fun. I was just there for his pleasure. I
mm,
didn't really get the message that this
mm,
is supposed to be a part of, the whole sexual um enjoyment and how
right.
to go about it. Because there's nobody to teach you, there's nobody to tell you really, um, until you start reading in depth, after you seek the knowledge,
Mm-hmm,
and then no, you don't even know if there is something wrong with you until you're saying, but this is supposed to go this way based on what the book is saying, and I'm not feeling this. How
right.
can we start that conversation, Doc? How
All
can we
right.
start that conversation with
So
a gyno?
I'm so glad that you asked that, because sexual
That's
dysfunction,
what I do. I ask the
right?
things that they all want to ask but don't want to ask.
I love that, because yes, so you're so right. And in office, a lot of patients will come to you and they sit down in your office and they ask you about everything. But the truth is, they really came to you because there's an issue with sexual
Right,
dysfunction. And so,
right,
how do you start that conversation? What I like to do is I start it for them. I take away the embarrassment.
right,
I have patients who come in and I just make it a part of my usual questions. Are you having sex? When did you have sex? I tell them I'm getting into their business, right? And they usually
right.
laugh, but they want.
Yes,
So I just ask them, in little ways, and okay, and how is sex going? And I remember I
right.
had a patient who says, no one has ever asked me that before.
That is
But
true.
you have to ask. And it ended up being a long conversation, because the truth is, women do have sexual dysfunction issues too, just like men. Our issues might not be the same as in a physical demonstration, in terms of a man who might have an issue with getting an erection, but we definitely have issues with desire,
Right,
arousal, orgasm, pain as well in
right,
sex. So
right.
it's important to speak to your doctor. A lot of women do not like to discuss sex. They might not discuss it with their friends. They may not even discuss it with their partners, that they're
That
having
is
issues.
true. That is true. Yes.
So I implore them, anything. I mean, the job of a gynecologist is we handle anything that has to do with reproductive system: uterus, ovaries, fallopian tubes, vagina, and sexuality, infertility, menopause, all of these issues. So it's under our purview of topics, right, that we can, on issues that we can cover. So I am glad just recently, I think a lot more women are coming in asking about sexual dysfunction. And a lot of people didn't think that young girls had sexual dysfunction. We always thought it was the older menopausal females that were having issues there. But young girls as well, especially for, as you said, issues with inexperience, lack of knowledge, sexual anxieties as
Mm-hmm.
well. And just
Mm-hmm.
because they are not exposed or they didn't know that they were supposed to enjoy sex, as you said.
Mm. It's
They don't,
dirty.
right. They don't come
Mm-hmm.
and they report it as a problem. But a lot of
Mm-hmm.
these things, I'm happy to say that a lot of sexual dysfunction is treatable.
Right.
They are possible issues. So definitely they should come and speak to their healthcare providers that they are having a problem so that we can find out what exactly the symptoms are. We
Mhm.
can evaluate you. And thereafter evaluation now we can come up with a treatment plan of how we're going to embark on solving this issue or treating this
Right.
issue that we'll be having.
Right. For
So,
example, I can use myself as an example. Like, I didn't know I had endometriosis until I was having very painful sexual encounters. And
mhm,
this is when now I went to Dr. Guthrie, and Dr. Guthrie, was saying to me, well, this is what is happening. This is happening here because I had fibroids before,
mhm,
and I had taken out some, and they had grown back, and then there was this growth on the outside, and one piece of drama. So because I'd never had heavy periods before, and now my periods started to be heavy, and all this, so I thought it was like change of life, and
mhm.
but many persons don't really seek the information. They think maybe it's normal because sex is supposed to hurt, and because if you're not well read and if you don't
Right.
seek the information, these are some of the things that people will suffer, whether silently or not,
So for
and not
real,
go
yes.
to the gynecologist.
Mhm, mhm. So I'm glad
So,
that you had mentioned
yes,
that about the painful sexual intercourse because that is definitely
yes,
a symptom for us when patients come and they tell us that they're having painful sex.
yes.
That's definitely something that needs to be investigated. So let me
Mhm.
tell all of the listeners out there, sex is not supposed to be painful. So if it is that
Absolutely.
painful sexual intercourse, then you need to be evaluated. As you said, there are issues. Patients could have endometriosis, there could be uterine fibroids, cysts. Some women suffer from a condition called vaginismus.
Oh,
Um,
that's a new one.
yes, so
Vaginismus.
vaginismus, and what that is that they have basically involuntary spasms of the muscles around the entrance of the vagina. So whenever they're about to have sex, basically they clam up and they're actually
Really?
unable sometimes to carry out the sexual act because there can be no penetration, right? So it's
And
very, very
that is due to anxiety, or what is that due to?
sometimes it's actually due to anxiety. And in patients that may have a history of sexual trauma or sexual abuse, or just, I suppose, sexual inhibitions for various reasons, causing this anxiety, and this happens. And there is treatment for it. Not a lot of couples, not a very common condition, really, but
Right.
couples have this issue and they suffer in silence. They're unable, I've had couples who are unable to consummate their relationship because
What?
of this issue with vaginismus. Yes.
And of course, the man makes it about she not wanting to have sex and being
Hmm.
paranoid and being inexperienced and yada yada yada, and get blamed for no particular reason, and you have this condition.
Right. And it can be treated. So a lot of these
Lovely.
problems, I said, they can be treated. So no need to sit down and suffer because of
Okay,
them.
great. Okay, so we have a question again. Is period pain symptomatic of an underlying medical problem?
All right. So there are many causes that of period pain. So the medical term for period pain is dysmenorrhea, right? So
Yes.
you can have different causes of it. So in some young females, they may have dysmenorrhea because there is just a constriction of the blood vessels in their uterus causing pain. There's actually no what we call structural problem. And in those patients, you can put them on regular painkillers. Sometimes they may find that later in life, after they've had children, they might stop having these severe cramps that they were having before. In other women, no, whenever you see dysmenorrhea, you need to investigate it because sometimes there might be other issues. There could be uterine fibroids that are there that are
Doc, what really causes? Is there a medical explanation for fibroids?
for fibroids. So fibroids
Yeah,
are really
fibroids.
just non-cancerous tumors or growths that happen in the uterine muscle. So
And is there anything that you can do to avoid them or
so
reduce them, or
usually they're
yes?
very common. 80% of women by the time they're 50 years old will have fibroids. So they are common phenomena in the body. Just like how persons can get lumps and bumps elsewhere on their bodies, these are basically lumps and bumps of the uterus. So there is a genetic predisposition in Black women, especially Afro-Caribbean women, to have fibroids. We have fibroids at an earlier age. We have multiple fibroids, and we have larger fibroids usually than our non-Black counterparts. So it's a genetic thing, right? So it's something that is inherent to women, and it's a genetic thing. But there are also things that can predispose you to having fibroids at a younger age as well. So, for instance, exposures to in diet. No, I don't want to tell everybody this, and then they all think it's because they have a bad diet that they have fibroids. That's not true. You have fibroids because you had a genetic predisposition to having fibroids. But things like diet, high sugar, high fat diets can also increase the size of your fibroids. Fibroids are also under the control of your hormones, your estrogen and your progesterone. So foods that can also increase the amount of estrogen in your diet can also increase the size and the number of fibroids that you may experience. So it's a hard question to say, what really causes them. It's really just that it's something that's actually very common in women. That's the truth. And then, but your genetics play a part in how affected you may be by your fibroids. So most women don't even know that they have fibroids. Only about 25%
until they get out of hand.
Right. So only about 25% of women, 25% of women even know that they have fibroids. And that's usually because fibroids cause an issue. The other percent of women, they don't know that they have fibroids because they don't have issues, and the fibroids don't affect them either. And if the fibroids are not causing any issues, then there's really no reason to go in and intervene at that point in time.
Okay. The role of HPV vaccine in sexually active women. Shelley.
Oh, the questions are coming. These are some hot questions. All right. So HPV vaccine. I was talking to you about health education. That's one of the things I love. Now I can talk all day about this topic. You might have to stop me, Sandra.
All right. I'll monitor you.
So HPV, that's the human papilloma virus. No, it has become very topical over the last 15 years. So we have found that cervical cancer, penile cancer, and some mouth and throat cancers are caused by a virus called HPV. So there are over 100 different types of this virus, right? Some of them are very benign. They're what plantar warts that you get on your fingers and your feet. That's also caused by HPV. But there are some strains of this virus now that actually cause cancers, the higher risk strains that can cause cervical cancer and penile cancer and throat cancers. So now that we have realized that these potentially very fatal cancers are caused by a virus, then, just like before when you had mumps and measles and tuberculosis and and polio, you develop vaccines to eradicate them. The HPV vaccine was developed to eradicate this virus and to boost your immune system to be able to fight it if it is exposed to it. So the ideal time, you talk about in sexually active women, but the ideal time to catch a virus or to kill a virus or to expose the immune system to it so it can fight it is before it was ever even exposed to it. So the ideal time to give HPV vaccines in young girls and young boys is before sexual initiation, which would be about age 11 to 14. So the average age of...
Hold on, stick a pin, Doc. So you're saying HPV vaccine is for boys and girls?
Boys and girls. So in the ideal...
I want to be clear about that.
Yes. So in the ideal world, both boys and girls should be getting this vaccine because you have penile cancers as well, right? And a lot of the time, the boys are silent carriers, meaning that they don't have any issues. They're carrying the HPV, but they don't have any issues. The female reproductive tract is much more sensitive than the male reproductive tract. So women get introduced to the virus, and we are the ones who end up getting precancerous and cancerous changes to the cervix a lot of the times. So really and truly, if you vaccinate the boys as well, then you're increasing the chances of eradicating these cancers, or especially cervical cancer, from your population. So
Okay.
really and truly, we should be vaccinating both boys and girls, but in an economic model, we vaccinate the girls, right? So the ideal
Is
time,
there an age group that we should start this?
this should be started from age 11, ideally. So what you
Wow.
want to do is, in Jamaica, the age of sexual debut, which is your first sexual interaction, is about age 14 for girls and 13 for boys. So really and truly, you need to vaccinate before this. That is when the vaccine will work optimally. So they were trying to do this in Jamaica, and up to 2 years ago, our government had started doing health education and promotion about the HPV vaccine and to give it in schools. There were some hiccups along the way, but they really should start it again. So in other countries, in the United States, in Australia, in New Zealand, it's a part of their regular immunization schedule that they get
Okay.
vaccine, right? And in these countries, we've definitely seen the rates of cervical cancer fall amongst their population as well. So the vaccine does work. A lot of persons are, when it was brought about in Jamaica as a part of our vaccination in young girls, a lot of people were skeptical. There was a lot of bad information, really just misinformation about the vaccine, and a lot of parents were very fearful to have their daughters vaccinated. But that is part of the conversation we talk about in your adolescent visit when you come in,
Right.
about
Right.
the vaccination for your daughter, right?
Wow.
So they
So there's
ask
so
now,
much information we missed out.
yes, 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 yes.
Yeah.
There's a lot to be had in this adolescent,
Yeah.
the gynecologist, a lot of things to do. So the STI conversation starts from even there, right? So HPV affects about 70% of the population. That's 70.
Are you kidding me?
Yes. 70%
What?
population is walking around with human papilloma virus right now. The majority of persons will never know, as always. They'll never know that they have it, and it doesn't affect them. But for the
Until
person,
something pops up.
right, but for the persons it does affect, then that is when we see the cervical cancers and the penile cancers, the throat cancers, the oral cancers, right? So
All
the
right.
price,
So as you touch on throat and oral,
Mhm,
does that have anything to do with oral sex?
for sure, for sure.
Okay.
So
So
in
can you
Jamaica,
touch
a
on
lot of
that a
people,
little?
right? So people used to like to say that when I was growing up, at least oral sex was taboo
Yes.
in Jamaica. People didn't talk about it, and if you did, it was you can we're not into that. But clearly we are into that, okay? Because oral and throat cancers have been around for a long time. And we now understand the genesis of it, so therefore we can understand that oral sex has been around for a long time in our population, right?
Right.
So it's the same thing. So the same introduction of the virus from genitalia to oral orifice that exposes you to oral and throat cancers,
Mm.
right? HPV.
And the transmission is the same from mouth to female or mouth to male, or it is more to male?
The same. So
It's the
female
same.
genitalia to male mouth, male genitalia to female mouth.
Okay. Wow.
Right.
Wow.
Yes, there's a lot of information. So this person had asked about in sexually active women now. So that is a good question, because a lot of persons ask, but if this vaccine ideally should have been given before you even started having sex, well, what about me if I'm sexually active? So there is still a role for the vaccine, even if you are sexually active. The reason being is that there are many different strains of HPV. So you may have been, even if you have been exposed prior, you've probably been exposed to maybe one or two strains.
Mm-hmm.
There's still many more strains out there that the vaccination will work to prevent you from getting. And two, the vaccination also helps to boost your immune system to even fight the strains that you may be carrying now. So the purpose of
Wow.
vaccination is to prevent you from developing cervical cancer. That is that's the worst outcome, right? So even if
Yes.
you have had issues or changes to the cervix because of HPV, the vaccine is supposed to prevent you from actually getting cervical cancer at the end of the day. So for
Right.
sexually active women, yes, we still do ask that they get vaccinated if they can against HPV. So I still offer it to my patients, and even patients that have come in with precancerous lesions that I treat, I still vaccinate them afterwards with HPV vaccine.
Are there any side effects to the vaccination?
The usual side effects of
No
an
side effects,
injection.
yeah.
So they may get just a soreness to the area of the injection. Some persons may complain of like a low grade fever the day or two after getting the vaccination. But usually I haven't had any poor outcomes, and the studies usually show that there are not many poor outcomes to vaccination. A lot of people were worried at one point in time. They were saying that the vaccine was going to give their daughters human papilloma virus. Nothing could be further from the truth than that. Okay, the purpose of it is to fight human papilloma virus, and people were afraid of neurological sequelae that might come out of it, and the studies really just have not proved that. This vaccine has been on the market for over 20 years now, so we have really robust studies at this point in time,
And
and
this
the
does not affect fertility, anything like
does
that.
not affect fertility at all. What would affect fertility is if you have a bad cervix. Okay,
Right.
that would be a deterrent to sexual intercourse. So this definitely does not affect fertility.
Okay. Mr.
Mhm.
Mr. Henry was asking about, he said that cervical cancer back in the days, in the days gone by, I didn't really hear much about it. I think though it's more access to information, I would
That's
think.
really what it is. So
Yeah,
cervical cancer
and
is
persons
actually
didn't really talk about
right.
these
So
things, even if they
cervical
were going
cancer
through it.
has been around for years. I remember one lady coming to me. She's around 40 years old now, and she said her mother died when she was a little girl. And I said, from what? And she said, I really don't know. I just remember her losing weight, getting sick. And one day she just bled from her vagina and died. And I went, okay, she probably had cervical cancer.
Right.
So a lot of persons didn't know what it was.
Was
Talk
right.
about thinking behavior and knowledge. They didn't know. So women out there, they had cervical cancer all along. They didn't know, and they got sick and they passed away. That's always how we
Right.
heard the stories back in the day. She got sick and she died. We don't know what she died from.
Right.
Cervical cancer was definitely there all along. It's just that now that we are diagnosing it in the population, but it was always there. So it's definitely not a new thing. It's actually, and now that we are seeing people actually coming to the hospital for treatment, that's now that we
Yes.
are now able to actually run the numbers, right? And the numbers may seem high, but the reason is they were probably much higher before, just that
Yes.
we didn't know what these persons had. They didn't seek help from medical
Right.
professionals at that point in
Right.
time.
Because the information just wasn't there, and people are afraid to go to the doctor.
Right.
They
And we
are
weren't
deathly afraid.
Right. We weren't screening for it now. The pap smear is
Right.
only about 60 years old. We weren't screening for cervical cancer. And if there was something that we're not even screening for, we're probably not treating it at that point in time. So it's always been around. It's nothing new. It's not a new thing at all. And it has nothing to do with diet either. It's because
Right.
of a virus, the human papilloma virus.
Serene, all the way from Cayman, she's asking, can you still get the vaccine at a late age? And what age would that be? Well, I suppose she meant, can you get it when you're old? I mean, still, is there a cutoff point where you shouldn't bother to get this vaccination?
All right. So most of the manufacturers will say that you can vaccinate patients up until the age of 59. So that is the absolute age that we use, up to the age of
59.
59. Mhm.
And that is there a reason for that age
Usually,
group?
yeah. So usually after that, then the natural history of cervical cancer. Most persons they would
Reduces.
have started having sex in their teenage years or their 20s. The virus usually has a progressive lifetime, and so we usually find that by
Oh,
the 50s, if you have not had abnormal pap smears or issues before, it might be unlikely after that to develop it. So getting the vaccine at that point in time really wouldn't make any sense. Or your exposure might have been quite great before that. So it wouldn't make any
Okay.
sense at that point in time to get the vaccine at that age.
Okay. All right.
But
So
women,
let us get a little bit
can I
now.
just put you, Sandra? So
Sure.
one
Yes.
women may ask me, I have women now who are in their 40s and now they've been divorced and they might be entering new relationships. Yes,
Right.
vaccinate.
Okay. All right. So, okay. So let us go a little bit now into the infertility, but I don't want to start when it actually happens.
Okay.
I recall back in the day when persons were getting married, persons used to check for things like, are you a sickler? I don't think that's happening anymore. I haven't heard anybody speak about that anymore in terms of, persons checking out your body actually before you get married, or seeing
Right.
if there's any kind of compatibility or no, non-compatibility between the two persons. Just touch a little bit on the whole infertility thing before you actually get there. Then, is there any checks you need to do earlier on in life before you actually say you want to get married, and or even if you're not getting married, you want to have kids? Is there anything that you should do prior?
All right, sure. So, not necessarily anything to do prior, but things to be aware of.
Right,
So,
aware of.
if you're a young female and you're having irregular periods,
Yes.
then this is something to be aware of that you might need to get checked out because irregular periods are abnormal. That's not a normal
Okay.
time. So if it is that you're having irregular periods, then that is something that you need to go to your healthcare provider about and check out because it may mean that you may have a difficult time getting pregnant.
Mhm.
Also, if you, as you say, you asked about sicklers. So before, I mean, once upon a time, people used to say to sicklers, don't get pregnant.
Mhm.
No, it's not that, you shouldn't get pregnant, but sicklers do usually have a more difficult time in pregnancy than persons who are not sicklers. And
Or
also,
checking if their partner is also
right, so as a
has a
so
trait,
that was
or
one of the
or
things that
yeah,
before marriage you may have done because you'd want to find out if your partner also carried a sickle cell trait or was also
right,
a person with sickle cell because you know now that the children, you want to find out what the children's odds of having
absolutely.
sickle cell would be at that point in time. If you're
Hmm.
a person that has a chronic illness, so for instance, you're a female that you have a collagen vascular problem,
What
you
is
may
that?
want so that's like
What
your
is
lupus and your rheumatoid arthritis.
okay?
You may want to get checked out because, again, a person with those issues should really be seeing a doctor prior to even that. They should be having preconception planning to make sure that they're
Right.
actually healthy enough to undergo a pregnancy at that point in time. So if you're
Right.
diabetic, if you're hypertensive, things like that, you should get checked out before embarking on a pregnancy. Not necessarily that those things cause infertility, but
Hmm.
we also talk about is it the best time for you to be trying to conceive as well.
Okay.
Uh, so, you should always get screened for STDs as well as a young female because there are some STDs that can actually cause infertility. So, for instance, your chlamydias and your gonorrheas have been implicated in what we call blocked tubes, tubal
Yes.
occlusion. People talk about having blocked tubes, right? So, if you have been exposed to these before, we should screen young women. If they have been exposed to it, then we can say that you might need to be evaluated. And there are tests that we can do to evaluate them to assess if they have blockages of their fallopian tubes or not.
Okay. Wow. It's a lot. It's a lot to be done, It's a lot
Yeah,
to be done, people. It's a lot to be done. And the truth is you really have to take your health into your own hands and be proactive about getting these things done. I mean, yes, you meet and you fall in love and you say, okay, all right, but you really have to do these checks prior
yeah,
to, a planned pregnancy or whatever, to ensure that you have the best outcome.
especially in the women over the age of 35 as well. So
Mhm.
as we know, fertility declines as you age, and in women,
Right.
5 is that hallmark age in which things start to decline for us. So you were talking about,
Like the viability of your eggs and stuff.
right, so your eggs have now aged. So the likelihood your eggs have now aged, you are aging. So every month things are not always, even though you get a monthly period, sometimes
Right.
you might even be ovulating every month, right?
Yeah,
And so
true.
you can check on that as well. Also, the eggs have now gotten older, so the quality of the eggs that you may have might not be as good as the eggs well, not even not might not, they are not good
Right.
as the eggs that you had when you were 20. So you may need to check on that because that can cause issues in getting pregnant as well as issues in staying pregnant. So your risk of having miscarriages also increases as you age. So that is something that a woman in her mid to late 30s can also check on before she can check on her actual fertility. There are hormonal tests that we can do to see how likely a successful conception may be in this patient.
What does exercise play in a healthy reproductive system?
Right. So
How does
exercise,
does exercise play any vital role in that?
yes, so exercise is vital to all functions of our body. So not even just infertility. So I mean, in anybody at all, any stage of life, you should always be promoting a healthy diet and exercise in these patients. So exercise keeps your weight down, which will also help with the fluctuations of hormones that women may have, which will then go on to increase their chances of having conception. So we should always remain active. And as you age, you should try to continue to remain active to keep your metabolic rate up, to keep your hormones balanced, and just for general longevity as well in fighting chronic illnesses. So,
Can you just touch a little bit about on incontinence, because persons will always assume that it's only older folks have incontinence, and that may not be so.
right. So the majority of patients who are incontinent are not always old folks. One of the biggest causes of incontinence is post delivery. So a woman
Right.
who has just had a baby, her
Or even
pelvic,
post surgery. Because I
yes, and
remember, yes,
right.
when I had my
So yeah,
myomectomy, was I had a little
right.
challenge there for a while.
Correct.
Hmm.
So, for instance, say a woman who just had a baby, the muscles down there have been stretched, the nerves have been stretched a little bit, and so she may suffer from incontinence. And a lot of women don't speak about this, they don't tell their friends. And so you have a lot of women coming into doctor's office afterwards and no one told me that I would have issues holding my urine after having my
Right.
child. And this in some patients can last up to 6 weeks, and in some patients even up to 1 year after delivery.
Wow.
Actually have to put them into pelvic floor physiotherapy to help them. And as you said, also patients who are post surgery may have issues with incontinence. So in your other patients, you have different types of incontinence. You have what we call urge incontinence, which is a
Hmm.
type where you can't hold the urine. You feel like you must use the bathroom right now,
Right.
or I'm going to make it in time, right? So that is urge incontinence, and that's usually an issue with the nerves in the bladder that can cause that issue. And then you have what we call stress incontinence, which is the one that usually your older women may get, where they find out as you age, things like coughing, sneezing, laughing, jumping, exercising, you may lose a little bit of urine. So it's important to go to your healthcare provider because they need to find out what type of incontinence you have, because the type is going to dictate the treatment that you will need. They're treated differently depending on the type. So you have to be evaluated as to what type you have, what are the possible causes that you may have, because we have women who have uterine fibroids and they get
Right.
incontinent because the fibroid is resting on the bladder, and so their bladder capacity has no decrease, and so they have frequency because of that. They have to go to the bathroom very often to the point where they find out that they might lose their urine, they might not make it to the toilet in time. And then you have your persons who have neurological problems, meaning that, persons who have had um, accidents where they've lost function of their nerves down below, and then they may have incontinence because they don't have any sensation of when to pass urine or not. And so they have incontinence all the time.
Okay,
So,
can we? Oh, yeah, continue.
okay, so I was just saying that. So, that's one of the things that I usually ask patients in office, especially after having children, after surgery, and aging patients, if they find now that they're having issues with their urine, where they're going to the bathroom much more frequently, or just they're having problems holding their urine now. But it's
And
definitely
speaking of
not.
urine, what I wanted to touch on is cystitis.
Okay, cystitis. So that's your patients who are having like their urinary tract infections. Very
Okay.
common in younger females.
Mhm.
Um, so causes of cystitis. One, you can tell women all the time when you're passing urine, you wipe from front to back. So if you wipe from back to front, which seems more natural to some people to do, or
Mhm.
you're going to expose your urethra as well as your vagina to the bacteria coming from the stool area. So that's a common cause
Oh,
of urinary tract infections. Another issue is holding the urine for long periods of time. So when you feel the urge to pass urine, you should go pass urine. All right? Because if
right.
not, the urine can stay in there for long periods of time, bacteria can grow, and then you get the cystitis afterwards. Also, remain hydrated to make sure that you are passing good amounts of urine throughout the day so that you can
Mhm.
flush your urinary system of any bacteria that might be in there. And then another issue is with sex. So we have what we call honeymoon cystitis. So for
Right.
patients who have recently changed sexual partner, or they're having a lot of sex, for instance, they go on a weekend vacation and they're having a lot of sex, they can also get urinary tract infections. So a good
Why is that? Is that because
it's
you're lounging in the moment, so you don't get up and have go
not
and have your
necessarily
urine? Not
just
necessarily, just
irritation to
back
the
to
urethra.
okay,
The urethra
okay,
sits right in front of the vagina. So if there's a lot of friction from the sex happening
okay.
in a short period of time, then the bacteria that would have lined the area, with the friction and everything, they get this cystitis as well. So I usually tell the patient, make sure you pee before and after sex.
Okay. Speaking of in infections, not infections. Speaking of not infections. When to douche and when not to douche, and is douching a good thing to do,
All right, when to douche and when not to douche. So
or
it's
is it
going to be
something to do?
right, going to be when you should never douche. So
Okay.
douching is a practice that is actually quite common in our population, but you should not douche. You don't need to douche. So the vagina is
But you have
actually
good bacteria and bad bacteria, right?
right. The
Okay.
vagina is self-cleaning. That's the first thing. There is bacteria that lives in the vagina and it is supposed to be there. These are
Mhm.
actually healthy bacteria that colonize the walls of the vagina and actually help it to fight infection. So when you douche, you clean away this good bacteria and then you leave your vagina defenseless. And so actually douching
Ah,
can opposite result than what you expected, where it can actually cause you to be more susceptible to having vaginal infections.
mm,
You should never douche, you don't need to. The next thing is that vaginal discharge, in terms of healthy discharge, is normal. All your vagina is supposed to be moist. The discharge that
right.
you have, that you see on your underwear, is a combination of vaginal cells, secretions from the glands of the cervix and the vagina, and it's the vagina basically washing itself out, right, and
Right.
cleaning it. So it is
So how
actually
so you know
an
something is wrong when there's like an excess amount than what you normally see, and it
right,
comes with a higher odor. Am I
right.
correct?
If you're having a copious amount of vaginal discharge, this may be cause for worry. Now, the good thing is that most women should actually know their own discharge, because your discharge changes throughout the cycle. So you can move from having a thick white discharge, no odor, not clumpy. And then you can have a mucoid discharge, where it's like a mucousy, egg whitey discharge, especially around the time of ovulation. And then you can actually have a watery discharge, depending on where in the cycle you are. So it's good to know what your normal discharges around the month are. So when you see something abnormal, like this discharge is copious, it's excessive, it's a different color. For instance, if it's not white or cream colored, it's now green, it's gray, it's brown. These are abnormal discharges. Your discharge usually doesn't have a scent, or you may have a personal scent that you know that's your normal scent, right?
Right.
Women, their normal scent is like. So if you have something that is a deviation from that scent, then you know that something is wrong. The vagina should never smell bad. It should not smell
Right.
like, it should not smell like anything rotten or raw, or these words I hear people describing their abnormal discharge as. So it should not have any funky odors, right?
Right.
You are sensing something,
Provided that you wash regularly.
right? Provided that you wash regular, and washing regular is at least once a day with soap and
Right.
water, right? And
Right.
ideally unscented soaps, because scented soaps can throw off the pH and the normal bacteria and cause problems as well. So provided you wash, if you are smelling an abnormal scent, then this is cause for concern, and you should speak with your doctor about it and be examined and evaluated.
Okay. So as we go to wrap up, I just want you to give us for an example of some of the tests that person should be, age group sensitive, as well as symptom sensitive. What are some of the tests that we should be going in for, especially if if it's something that, it gives you a second thought, like, never saw that before, or never felt that before, or, or somebody, I don't know if you graduate from stage to stage, if there are certain tests that we need to do as we age.
Sure. All right. So over the age of 18, one of the tests definitely that I'd recommend is that you have yearly STI screening. That's your sexually transmitted infections, to be screened yearly for those. In addition to that, your pap smears, your screening for your cervix should start at age 21. And
Right.
the frequency will change as you age as well. So usually between the ages of 21 and 30, you're going to be screening about every 2 to 3 years.
All right,
Now,
question, doc. Stick a pin. Is this whether I'm having sex or not, or only if I'm having sex?
so we screen at age 21 regardless of sexual activity.
Okay.
Right. So regardless of sexual activity, the guideline is to start screening at age 21.
Okay.
So we will screen, in our population, we tend to screen women annually. But you can screen every 2 or so years if it is that you are having normal pap smears and you have a normal pap smear history. In our population, sometimes we have women who are opportunistic pap smearers. They come to the doctor for a reason, for a particular issue, and then we capture them at that point in time.
Right.
Those patients, we usually have to tell them, you need to come every year. But in the patients that are well motivated, who will be in your office every 2 years, they have never had an abnormal pap smear, then you can screen them every 2 or so years. When you turn 30, we introduce what we call co-testing screening of the cervix, which now means that we do a pap smear as well as doing a DNA test of the HPV in your cervix. So we actually do the screening for abnormal cells as well as we do a DNA test to see if you.
And this age is what? Is age what
30,
again?
30. To see if you are exposed now or if you are carrying any HPV virus. If it is that you are not carrying the HPV virus,
I'm trying to think if I've ever had one.
Maybe you have, maybe you haven't. A lot of people have not done that. If it is that you are not carrying HPV, then you can actually screen every 5 years.
Right.
But people are not doing that, so they continue just doing annual pap smears, right? So that is one option. You can continue the regular frequency of pap smears, or you can actually do HPV DNA test, which now, if you are negative, you can screen less often after the age of 30.
Mm.
If you're having
Is there a correlation to if my mother had cancer or any kind of issues to do with her
yes.
reproductive system? Should I go in earlier or?
All right, so let me start off. Although it's not really a part of the reproductive system, the breasts. Let me start off with the breasts. So your gynecologist should be checking your breasts whenever you go in for your visits on an annual basis. So if we know that breast cancer can be hereditary, you have persons who have different genetic predispositions to breast cancer, whether different syndromes, BRCA syndromes, Lynch syndromes, and other syndromes that you may have. So if you find that you have a relative in your family who has breast cancer, especially a first degree relative, first degree meaning your mother or your sisters, who have been diagnosed with breast cancer, then your screening should start 5 years earlier than the age they were when they were diagnosed. So, for
Mm,
instance, start mammograms in Jamaica at age 40.
okay.
But if your mother or your sisters developed breast cancer at age 42, then you need to start screening at age 37 for breast
Mhm.
cancer.
I
And
had
then
breast cancer at 35,
right, so
and
you're
I was young and active and no
correct.
history in my family. So the thing is really, as I always say, is to know your body, check your body, check for every lump, bump, anything that is abnormal, anything that wasn't there last week or last month or last year that is there now.
So we
Don't
tell
take
ladies,
anything for granted.
do not. So I implore my ladies out there to be what we call breast aware at this point in time. So
Hmm.
know what your usual breast looks like, feels like.
Hmm.
You know, on a monthly basis, usually choose the same time in the cycle, every cycle, because your breasts change throughout the cycle. Whether it's before the
Hmm.
period, or the period, or after the period, they actually change in how
Right,
they feel. So choose the
right.
same time of the cycle and examine your breasts. Look at them, really look at them. Know what your body looks like. Look
Hmm.
at your breasts and then feel your breasts as well. So you know you are breast aware. You know when something is different this month about your
Right,
breast. And then you can
right.
go to a care provider who can then examine and evaluate the breasts as well.
Hmm.
So sometimes, as what happened with you, Sandra, you had breast cancer at 35, no family history of it prior, but because you were able to, know what was going on, you were able to seek help. And I know you're a breast cancer survivor, so you're here,
Hmm.
proof,
20 years,
right?
going
Right.
21.
Congratulations, congratulations. That
Yes.
early
And I
prevention,
was a
early,
stage two. So as long as you catch it early,
right?
and be
Early
proactive about
detection
it,
and
you can
prevention lives.
absolutely,
So that is the
absolutely.
reason why we do, as you were talking about these tests, people are, they come and they ask, what is all this screening about, doc? And that is the purpose of screening, to catch things before they become
Right,
cancer, the ideal situation, but then also to catch it early if it is
mhm,
cancer, because
right,
then that can save lives, of course. So we screen
right.
for cervical cancer. We're very serious. We have to be very serious about screening for cervical cancer, especially because you can catch things from a pre-cancerous stage before it even becomes cancer, and treat it before it becomes cancer. So cervical cancer, we can treat it. You can prevent you from getting it with a vaccine. We can catch it at a very early age or before it even becomes cancer, and get rid of those abnormal cells if it's caught early. At age 40 now, you're going to be starting your mammograms, your regular yearly mammogram. At age 50 is when we start sending you for colon screening, for you to have your colonoscopies done every 5 years. So these are your usual screening
I'm
tests that you're
doing
going
mine
to,
now. Yeah,
yes, throughout your
yeah.
lifestyle.
Mhm.
Now, as issues may come about, patients come in, they're having heavy menstrual periods, they're having irregular periods, they're having infertility. Other tests that we can do now is, of course, um, a pelvic ultrasound, invaluable method of evaluation, right? So a regular pelvic ultrasound can give us a lot of information as what's happening with the female. Other tests we can do if you're having hormonal issues, or we suspect that there are issues with the hormones, is doing what we call a hormonal panel in women, which basically is a
Okay.
test to see what the levels of the reproductive hormones, as well as the thyroid hormones and another hormone called prolactin, is in your body at that point in time. So we do this in all our patients who have hormonal issues, like your patients with polycystic ovarian syndrome, as well as your patients who have irregular cycles, and your women as well who are coming in with issues of infertility or subfertility. Another test that we can do, for instance, as you were saying, to find out if the tubes are blocked, that test is called a HSG, a hysterosalpingogram, where we actually put dye inside of the uterus, and we look for the delineation of the dye in the uterine cavity and into the fallopian tubes, and then we look to make sure that the dye has also spilled. So this will tell us that the tubes are open, right? And there are also more advanced tests as well that we can do to check on the tubes being open as well.
Okay. All right, doc, that's a lot of information. Mr. Henry says, I heard that there is a particular blood type that might create difficulties with pregnancy. Is this a myth?
All right. So what he's probably speaking about, Mr. Henry. Mr. Henry coming in with all the questions tonight.
Yes,
Thank you.
man. He's my best student.
All right.
So he'll be able to do medicine.
The blood type that you are probably speaking about, Mr. Henry, is what we call is the rhesus status of the patient. So you have two different types of blood categories, right? So you have the actual type, which is like your A, B, and O. So when people talk about type A, type B, type O, but then you look at the other part, which we call the rhesus status, which is the positive or negative. So when people say that like they're A positive or they're O negative. So if you are negative, you're rhesus negative, this can cause an issue in your pregnancies, because negative is usually the uncommon blood type. Most persons are going to be positive. 80% of persons are going to be rhesus positive. So if you're a woman and you are rhesus negative, the chances are that your partner is rhesus positive, and then the baby is going to be positive. Because being rhesus negative is what we call a recessive blood type. So it's only if both parents are negative can you have a negative. Once there's a positive and a negative, the child will be positive. So in that scenario, the first pregnancy is usually fine, right? But what happens after that is that the mother, because she is rhesus negative, exposed to this rhesus positive child, she develops antibodies to this blood type in her body. So that her next pregnancy, if she has another baby who is rhesus positive, her body is going to attack that baby.
Are you serious?
Yes.
Never heard of this.
Right. So we talk about these things like, oh, is it something that is new? So you have women who all along they had these pregnancies and they said, oh, I keep having stillborns or my babies keep dying. Right. For years, the people didn't know what was causing it. But this is a thing, blood incompatibility. So what we have to do is we screen. This is a part of your antenatal screening test. All women who are pregnant, we send them for blood tests. And the reason we do that is to find out if you have a rhesus negative blood type, so that we can intervene. Because if it is that
you're going out a bit. I don't know what's happening. Oh yeah, yes.
Are you hearing me now? So we can
hearing you, yes.
Right, we can intervene. So we screen the mother. We screen if she has antibodies to rhesus positive already. And if she does, we know now that this is going to be a high-risk pregnancy and we'll have to monitor her. And that during the pregnancy, we start giving her injections. And these injections are basically injections that go into the mother's bloodstream, and they basically mop up all of her antibodies that she has created. So it prevents her blood type from attacking the baby's blood. So we mop up all of the antibodies and we prevent this issue from happening. So we give the mother these injections during the pregnancy, and we also give her again within 1 week of the pregnancy being over. And then in the next pregnancy, we go ahead again and we screen them to see if they have any antibodies that were there. And then we'd have to monitor these pregnancies closely.
Wow. Whew. I mean, people make having babies look easy, but it's not that easy, is it?
A lot of persons come to you and they say, well, why should I go to an obstetrician? My mother has 10 children in the country and she had them at home. I don't see the need. Ignorance is bliss sometimes, because a lot of issues do happen in pregnancy, things that are very preventable. A lot of persons, especially now, your pregnancy is not your mother's pregnancy. We live in a world,
Right.
diet is different. Girls are having chronic illnesses at a younger age than their parents did. And all of these things can affect your pregnancies.
Wow.
So clinic is a must. You must go and seek early antenatal care. And actually, what we're pushing for is not just antenatal care, but preconception care. When you decide that you want to get pregnant, you should actually go and see your doctor before, to make
Right.
sure
Be
that this is
proactive.
actually a good time, right? Be proactive about it. This is a good time if you are healthy enough at this point in time, because there are things that we can fix to try and ensure that you do have a healthy pregnancy when it is that you become pregnant.
Okay, great. Carol says, why women get when they get older, they get dry and loses their sex drive.
Right. So that's a very common issue, Carol, that happens as we go through the menopause. So the reason being, it's really a lot of hormonal issues that happen. So when we are young, we have estrogen pumping through our veins, literally, and through our body. As we get older and we go through the menopause, the estrogen levels in our body decreases. And estrogen is in charge of that vaginal wetness that we talk about. So as women get older, that is one symptom of the menopause that you can look for or screen for in your cells before you go to your doctor, that you're experiencing vaginal dryness, which may come along now with what we call genitourinary symptoms. So they're having itchiness, soreness in the vagina, or they're now beginning to have painful sexual intercourse because they're not lubricating well. So that is really because of decreased estrogen levels. There are ways that we can combat it. If it's an issue that is affecting sexual intercourse, we can, prescribe that you use lubricants with sex to assist you with your wetness to the vagina, as well as we can actually give you topical estrogen creams that you insert into the vagina a few times a week, that will actually help you to increase the estrogen level in the vagina, therefore increasing the suppleness of the vagina and the wetness of the vagina again.
Okay. Well, Doc,
There
I
was
think
somebody who had a question. Sorry. What is the likelihood of someone with
oh yes,
fibroids
yes.
getting cervical cancer? All right. So that is kind of like a question with two different things, Kadian. So fibroids really have no relation to cervical cancer at all. So the likelihood of getting fibroids in our population is about 4 out of 5 women, pretty high. Cervical cancer incidence is a lot lower. We're talking about amount of persons out of 1,000 persons that will develop cervical cancer. So they are completely mutually exclusive entities. So likelihood that you have cervical cancer and fibroids might be high, just because the likelihood of having fibroids is high, but they're not related issues at all. They're not related. So fibroids don't cause cervical cancer, and cervical cancer does not put you at risk of developing fibroids, and fibroids don't put you at risk of developing cervical cancer.
I want to be the devil's advocate. Speaking
Mm-hmm.
about vaginal dryness,
Mm-hmm.
suppose I'm just bored with my partner. How do you know the difference from me just not being interested in my partner versus me just being dry from aging?
From
Is
aging.
there is there is there a, is there a difference? Is there
So,
a
yeah, so it's there. I mean, well, we can look at the life cycle that you are in, right? So
right?
if you're a person that is now perimenopausal, menopausal, or postmenopausal, then there
And
might
peri
period
meaning
around the time of the menopause. So
okay, which is
in
normally what age?
about 5 years before the last period is perimenopausal. So most women are about
And that is
45
what normally 50, 55, 60.
or 45.
When
So
does when does menopause happen?
all right. So the average age of menopause in our population is age 51. That's the average
Okay.
age. But this is always a range, right? So women can go into menopause as early as 45 and as late as I've had women up to 57 still menstruating. So we usually say about 5 years before the menopause is the perimenopausal period. So I would just say, give or take, about age 45 is when we probably should start looking for changes.
Mhm.
So one of the symptoms that they will go through, you have hot flashes, and they might now start reporting that they have vaginal dryness, right? So they have vaginal dryness, itchiness, soreness, burning upon sexual intercourse. So the age might give it away that it might be that you're going through the menopause. That's what's causing the dryness. But you'd ask a good question. What about lack of interest, an issue with
Yes,
desire?
they're just not turning me on, and I'm just bored out of my
Right. So
skull.
that is definitely an issue. So those things now we have to delve in the meeting that you're having, where
Right.
okay, I'm sure you still are desirous of this
Of this,
person. Are
this
you
right.
aroused by this person? Are you enthusiastic and interested in sex? Other things that might be happening. Do you have any chronic illnesses that are uncontrolled? Is your
Oh, you're on
diabetes
any medication?
right? Are you on medication? Do you have any issues with depression? Are you pregnant? Pregnancy can change a lot of those things,
Mhm.
vaginal dryness. Are you stressed out? Because if you're stressed out, you have zero interest in sex a lot of the
Are you
times.
broke? Having body issues. Money issues
Exactly.
tend to make vagina
Right.
very dry.
Issues, exactly. So financial issues, work issues,
Yes,
relationship issues, your partner just not
yes. Just
so
not clicking.
exactly. So we have to delve into a lot of those things to find out could this actually be psychological versus
Mhm.
an actual physical cause of the dysfunction. So we can also try and do some tests. We can test your estrogen levels to see if your estrogen levels are particularly low. And if they're low, then we can give you some medication to improve the estrogen levels and see if that symptom improves afterwards.
Okay. Betty says, is that typical estrogen treatment safe for breast cancer survivors?
All right. So in all persons, we have to, before starting, assume what you're
But I
talking
think
about.
no, she said topical. She didn't. She corrected in the next one. She said topical is
Topical.
not typical. Topical estrogen
All
treatment.
right.
Yes.
So usually when we're talking about adding back estrogen in women, we have to screen our persons appropriately to make sure that they don't have any estrogen producing cancers or family history of any reproductive or estrogen producing cancers, right? So what you would want in a person who has had breast cancer before is that you want something to also oppose the estrogen. So you want a little bit of progesterone as well, so you don't have unopposed estrogen in the system. So topical estrogens now usually are far less systematic or systemic. They go less into the system than the oral or other versions of estrogen. So what I would have to say is that we'd have to make sure, we'd have to look at all the different factors. How long ago did you have breast cancer? Did you know the type in terms of it was an estrogen, a progesterone positive type of cancer that you may have had before we can decide? So a lot of these things may be at the discretion of the doctor who actually knows your case very well to decide if a topical estrogen and of course what dose would be the best for you. So it's not something I can just say a sweeping yes or a sweeping no about.
Right. Well, I mean, I know some of my girlfriends because I don't take anything because of my situation. But and I mean my 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 period was, I mean, I went into early menopause because of
Mhm.
the medication that I was on because of the tamoxifen. So I went into menopause at age 47. But I mean, I
Right.
had a period of really heavy sweats and stuff. But I mean, not after that. I was kind of every now and
Mhm.
again you have a little moodiness, but then who is not moody? You know what I mean? But my
Right.
experience, I wouldn't call it bad. But
Mhm.
I know that some of my friends take something like evening primrose. And what are your views on those
Those
natural products?
all
Do
right.
you
So
think
my
they work?
so
And I think black cohosh or whatever. I don't know
right.
the names, because as I said, I didn't use them, but I know I
Mhm,
hear them talk about it
mhm.
because
So with
I'm in that age group.
So we treat the menopausal symptoms depending on what the symptom is. And women do suffer from different symptoms as well. So you will have what we call the vasomotor symptoms, which is like the hot flashes. So usually for those symptoms now, we can start everything on a ladder basis, right? So we can start with the natural remedies like the black cohosh and the evening primrose. Now, the studies done on those things are, I would say, they have been inconclusive, meaning
Right.
that some studies come back saying that they work once they're appropriately dosed. And then, no, that's a whole different study to find out what the appropriate dosing is for them. Because some persons say, oh, I take one a day, right? But when you look on the container, one is like a quarter of what the daily recommended dose is. So they really need to be taking more of this tablet a day. And then some studies come back saying that they don't work. So what I usually tell patients is to try it. Try it and see if it works for you. And the same thing, I have patients who come back saying that they do feel better after taking it.
Right.
Some patients who might say, well, no, I don't think it worked for me. And if that is the situation, then now we can move up the ladder after that to another type of intervention or other types of medication. So that's going into the realm now of hormonal replacement therapy. Not all hormonal replacement therapy is always just estrogen. We have other methods that are not just estrogen. They're estrogen, progesterone. There are different types of estrogen, ones that are more physiological, like the actual estrogen that we as women produce. There are some that are estrogen that are derived from horse urine. They call that equine estrogen.
Wow.
And other aids now, like medications that are like tibolone, that are other types of hormonal type of medication that are not estrogen based, that especially women who might have had a breast cancer, those types would be more safe in those patients. So it comes down to really, it's a conversation that you would have to have with your doctor, because it's going to be personal, a personal conversation about all of your illnesses, all of your exposures, all of your history with
And what
cancer,
you're currently on.
what you're currently on, what you've been treated with in the past as well for your cancer. So we know which method we would want to try or not try. Or how much timeline we need. We need maybe 5 years before you can do something like this.
Would you say exercise also helps during this period as well? To
Exercise
kind of
definitely.
balance out your moods
Yes.
and your
So for sure. So a lot of patients in the menopause go through the mood swings. They have issues with sleeping as well. They have a lot of sleep disturbances. They suffer from insomnia. And definitely exercise will help with that, with giving you a good night's sleep. Exercise can also help a little bit with mellowing out the erratic hormonal changes that you may be experiencing. So I definitely promote exercise, especially too, because when there's a decrease in the amount of estrogen in your body, you're susceptible to decreased bone density, which now will cause osteoporosis. So you need to be taking your calcium and your vitamin D, and also be doing your exercises to strengthen your bones as well, your weight bearing exercises. Um, Another thing is that with the menopause, your estrogen levels decrease, and estrogen was really helping a lot with your cardiac health. So when you are going through the menopause, you need to be screening as well for your lipids. You need to be doing your executive profiles on an annual basis to see if your cholesterol levels are increasing, making you more susceptible now to having heart attacks and strokes. So exercise, as we know, is beautiful in helping to prevent a lot of these chronic illnesses as well. So exercise is very important.
weight management.
And weight management. So actually, at age 35, definitely you need to start. You need to beef up your exercising. If you have not started, you need to start by age 35 to help give you that good bone density now going into
Right.
the menopausal period.
Right. Lisa's asking, can you be on birth control pills too long?
Hi, Lisa. So, in a nutshell, you can't be on it for too long. But what I would tell women is
How
that
long
make
is too
sure
long?
we can have women on birth control pills as long as they're on a pill that they don't have any issues with, it doesn't cause any nausea, they're not getting any abnormal bleeding. You can be on birth control pills for 20 years if you don't want to have a child. What we tell you now, the too long, is that you should actually be coming off of birth control though, about
Give
the
yourself
age
a break.
of, well, in your late 40s. So going now towards your menopause period, you want to be coming off of birth control because the exposure to estrogen at that point in time, you want to decrease the exposure to estrogen when
Get you.
menopause. So you can come off at that point in time. If it is that you like the effects, you can go on a lower dose or one of the hormonal replacements that have really, really low doses. So I wouldn't take the oral contraceptive pill over the age of 45. And also in
What
women,
about the patches?
the patches,
Mhm.
same thing with the patches. And especially in women who are hypertensive, diabetic, have kidney disease, you really need to be screened appropriately to find out if you should even be on the oral contraceptive pills. Now, what is in vogue right now with a lot of girls or women is that they are taking the pill continuously, meaning they don't take the week off. And so they take it for the whole year and they don't want to have periods at all. No.
What?
Yes, a continuous method of taking the pill. So they don't have periods. So what I would say is that this is not the ideal practice. You should have at least 3 to 4 periods a year. So if you're
Why,
gonna take
why,
the pill,
why would they do that, doc?
some
Just not,
persons
just
don't. I mean, like you
not
have
to have
persons,
periods?
yeah, they don't want to have periods, or I mean, sometimes we even manipulate it like that. For instance, if we have females who come in with history of heavy menstrual cycles, and every time they have a period, they bleed for long periods of time, they end up needing blood transfusion, then you want to stop the period. And so you may
Oh,
have to take it
because they
continuously.
become anemic.
Right, to build back their blood count in this period of time. But we
Mhm.
usually say that you need to have a bleed at least every 3 or 4 months because the lining of the uterus can actually get quite thick. And so you should actually try and induce a bleed. And if you don't, what may happen is now that you can start having what we call the breakthrough bleeding when they come in that they've been on the pill and they know they're having this random spotting all the time.
Right.
So usually when that happens, you should just take a break and and actually have a withdrawal bleed at that point in time.
How do you know if you have high estrogen level, and what does it mean if you do?
All right, so a high estrogen level now usually doesn't come on its own. Usually it's going to be a part of the other hormones as well being unbalanced. So, for instance, patients who have polycystic ovarian syndrome, they tend to have a high estrogen level because there is a disorder of estrogen. Is there a way to really know that you have high estrogen levels? Not usually a clinical manifestation. We usually have to do testing, like blood testing, to find out what exactly the estrogen level is at that point in time. If it is that you are exposed to high levels of estrogen, there can be um, detrimental sequelae in terms of you can put yourself at risk of developing certain types of reproductive system cancers as well as breast cancer, sometimes exposure to unopposed estrogen. So if that's the situation, usually we may want to manipulate it with other hormones, like putting you on the pill as well.
Okay.
Mhm.
Well, I think we have covered. Ethel says a very interesting, and quite a few other people too said a very interesting and informative. A very thanks for making her evening, Astrid and Sandra. You are so welcome,
Very
Ethel.
much,
My new Facebook friend. My new Facebook friend. We have become friends over the last couple of months. Thank you
Great.
so much. I don't even know where to start in terms of telling you how grateful I am. I mean, you are indeed the perfect person.
Thank you so
You
much for
are
having me. Thank you for
so
covering me.
full of the information, and how you explained it and expressed it to our viewers. And we could not have asked for more. We
Thank
will.
you. I enjoyed myself because I'm
I am asking you now. Just repeat where
uh
they can find you, and we will continue to run it. We have your information, but just let them know, because I'm sure there are many persons because they're very shy, Because I tried having a discussion after my first season just to discuss. Not a soul took me on, doc. Not a soul, because they're shy, and I understand that they want to inbox me and they want to talk to me privately, or they want to talk to the doctor privately, and nothing is wrong with that.
No, nothing is
As
wrong.
long as you seek the information and do something about any issues that you're having, that is what you need to do. And this is why we have this forum, so that we can bring you the information. So that if there's anything that is happening with you, you can take the move, the step to do something about it. So can
Yeah.
you just please, Dr. Batchelor, just let them know again where we can find you and a number that they can find you at.
Okay, sure. So you can find me at Gynae Associates Kingston. That's at 23 Tangerine Place. That's just off of Halfway Tree Road. It's right by where Medical Associates is located. And the number for that office is 929-3058. Also, I'm at FemCare Gynecology and Pregnancy Center, and that's at 34 Lady Musgrave Road. And the number for there is 630-1240. My
Awesome.
handle is Instagram. I am Dr. Astrid Batchelor on Instagram. I am Dr. Astrid Batchelor on Facebook as well. And you can also Google me. I can be found on Google.
Awesome. And if you look on my page, all her information is there on Instagram. I believe it's on to our Totally Mail page. I need to put it on my Samuel Sandra page. I will post that as I finish here. You can get the information. I will post the information there. Thanks once again, Dr. Astrid Batchelor.
You're most
Awesome,
welcome.
awesome, 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 awesome. I mean, anybody would be more than happy to come to you, because you make me feel relaxed. We can ask any question and you just let the information flow, and you're so open and full of information. Thank you so much for joining me tonight.
And thank you for
I
inviting me. Thank you for having
really
me.
appreciate it.
Friday.
Thank you, thank you, thank you. It was our pleasure having you. So next week, family, my family, next week, same time, same place, 8 o'clock. Samuel Sandra at on Facebook Live, or Totally Male Spa Facebook Live, or on Totally Male Spa on YouTube Live. And as you know, it is posted immediately after the program finishes airing. So if you did not catch the first part, you can always go back when you have the time to listen to all the information given. It is a wealth of information. You really don't want to miss it. As I said, to miss, you have missed out. So please subscribe also on our YouTube page. Check out some of the past um, interviews that I have done, because a lot of information was shared. So thank you for joining us. Thank you for staying with us. See you again next week. Peace and love. Good
Peace and
night.
good night. And good
Bye.
night,
Bye,
everyone out
dog.
there. Bye bye.
Bye.